welcome to this lunchtime session. At the outset, just to indicate the session's been supported by Perfuse Medtec, and thank you to them for putting this session on. So what we'll be talking about today is the Canadian Consensus Statement on the Management of Venous Leg Ulcers. So this is something that a number of you have probably heard about through different fora in the last few months, and heard a little bit about it yesterday at one of the sessions and also in the posters. There's a poster on this. But today we're going to walk through the overall process related to that. So we'll briefly do some introductions and then we'll go on to a few questions for yourselves. So get your phones ready for the questions. Then Dr. Sibyl will go through some of the evidence behind, why we're talking about using MPA or muscle pump activator in treating venous leg ulcers. We'll go through the consensus statement itself and then have some clinical cases, which Amanda Loney will sort of walk us through. And then any questions in what time remains. So firstly, just to introduce ourselves. So I'm Michael Stacey, I'm a vascular surgeon. I've got a long-standing research interest in chronic wounds and venous leg ulcers in particular. I work in Hamilton, at Hamilton Health Sciences. So I'll just go down the line and get each of the panelists to introduce themselves. So Gary, start with you.
I'm Gary Sibyl. I'm a dermatologist internist with an interest in wound care and education, professor at UT, and I run Project ECHO, which is free for Ontario citizens, and the International Interprofessional Wound Care course, which is not free.
I'm Dr. Robin Evans, and I think most of you know me. I've been here all day and yesterday, but I'm a family doctor and director of the Wound Healing Clinic at Women's College, and I do the wound care educational programs for Wound Canada. Thank you.
Hi, good afternoon. I am Amanda Loney. I am a nurse specialized in wound ostomy continence for approximately about 26 years, and my area of practice is in the community and in long-term care and private practice.
Great, thanks everyone. And just want to acknowledge that we have a number of the panelists who are involved in developing this consensus statement in the audience. And we'll put up the names of all of those involved as we go through the process, but I welcome all of them as well. And if you have questions for any of them, feel free to ask them about this as well. So I'll hand over to Amanda, who's going to just go through those initial polling questions for all of you.
So I really want you guys to take your time to answer these because we're going to see how well we do in answering these later on. Okay, so we're going to go. Question number 1. A 55-year-old male patient confirmed with a VLU has been wearing multi-layer compression that has been applied correctly for 4 weeks, and the ulcer has reduced from 28 square centimeters to 25. What are your next steps? So I had to actually do this calculation because I don't normally deal with square centimeters. I like the percentage. So I think this is in and around like 10 or 10.7% healing. So A, do you continue with current treatment plan? Change to a different dressing? Add MPA? Or change compression systems altogether? So I think everybody, it's kind of the MPA, your muscle pump activator is MPA for those who haven't kind of been listening earlier. Okay, so I think we're good there. So let's move on. So question number 2. A 75-year-old female patient with a leg ulcer with the typical appearance of a VLU with claudicates at 100 M and has an API of 0.8. What is your plan? So number 1, refer to a vascular surgeon. Number 2, add your muscle pump activator. C, apply a lower level compression system. Or D, all of the above. So just like when you're looking at the 100 M, so that means if they like walk 100 meters, that's when they start to get the pain. Okay, let's move on. Question number 3, a 74-year-old male patient with confirmed VLU refuses to wear any compression. What is your approach to management? Continue to try and convince him to wear multi-layer compression. Try a dressing plus a stockinette. Use a dressing only, or use a dressing, stockinette, and your muscle pump activation? You guys are doing really good. I think we can go home. Okay. Okay, so now we're going to switch it over to the evidence for use of your muscle pump activation.
Okay, so let's look at the evidence, and we do have evidence for muscle pump activation. And I think it's interesting, if we look at an increase in blood flow with venous volumetric flow, it goes up to 100% increase, arterial up to 75, and microcirculatory flux up to 400 increase. And increases in blood volume and velocity up to 60% of walking without having to move or exert any energy. Oh boy, now they're working right from the start. Thank you at the back. Baseline, and when you look at a laser speckle contrast imaging of the microcirculatory flow in the wound and peri-wound area, look at what it does. The device increased the perfusion to both the wound bed and the peri-wound area, 225% increase in flux in the wound bed. And this is often associated with a twitch response. In peri-wound, there is a 67% increase. And when we look at speckle peak venous velocity, and with the patient or subject recumbent, you get pretty good flow. When somebody's seated, because of the seated position, there is a decrease in flow, but yet there's still quite an increase with the Gecko device. When you look at speckle pulsativity, and you look at the wound bed, and you look at the peri-wound, you'll see that there is microcirculatory pulsativity without the neuroelectrostimulation device, or what we're calling it, the muscular pump activation. So this is a random controlled trial. And I'm quite amazed that in the UK, Bull and colleagues, including Keith Harding, could actually do this kind of trial during COVID. Because it's extremely difficult to do clinical trials. And what the trial showed, and this is a little bit different design than you may be accustomed to. So the patients on day 0 were recruited. The patients were not randomized to day 28. And so what happened in between was in the screening, they might have failed the inclusion criteria or the exclusion criteria, and there were 56 subjects. They might have met eligibility, but the wound was too small at randomization, so this is 4 weeks later, 26. Wound was too big, the 4. Index wound infection 2, or they were lost to follow-up with COVID, and that was 23 subjects. By day 28 at randomization, you're down from 171, you're down to about a third of the patients at 60. And at that stage, the patients all received compression. In addition to compression, so that's the standard of care here. In addition, we had the muscle pump activation, or on the chart, it's the neuromuscular electrical stimulation. There were 34 in that group, and standard of care 26. So those patients were followed for an additional 4 weeks. But even after the 4 weeks, so this would be week 8, there was still follow-up at week 12, 16, and 20, even though some of that follow-up was by telephone. And you can see there was non-compliance, or I prefer the word adherence. There was wounds that were too small at randomization. There was eczema around a site, and there was one that probably wasn't a venous ulcer and was dropped out. And if we look at the demographics of the subjects and we look at age, height, weight, here you see BMI roughly equal. And if you look at the t-test over at the far end, none of them were statistically significantly different. And you heard about the ABPI for those of you that were in the last session, ankle brachial pressure index. I actually prefer to do an audible Doppler and listen to the signal. And if the signal is biphasic, which is or triphasic, any multiphasic wave, and we validated this in 200 patients, and we actually showed that it was 98% accurate. But you always look at whether there's dependent rubor and it goes pale on elevation, or they've got claudication, or the foot's cold. So you really need to look at other symptoms. But the audible Doppler is something you can record on your cell phone and you can get verification. It's very hard to get verification on a palpable pulse. The wound size was the same. The age at study enrollment and the age of the first venous leg ulcer were similar. So what it showed, and because some ulcers were smaller, some were larger, this PAR is perimeter area reduction per day for all subjects randomized to the standard of care during the 4-week run-in and 4-week treatment. And you can see that during the treatment stage, the run-in, though they did receive compression, and during the treatment, there was a very slight increase. When you look at the muscle pump activation effect plus compression, the perimeter area reduction was much greater. And so that this was an even greater change. And what's interesting, but not in the slides we're presenting today, was that that increased rate actually continued at week 12, 16, and 20. So it didn't stop when the device was discontinued. The device is put on for 12 hours on and 12 hours off each day. Here we look at the healing rate, and with the muscle pump activator device, it was twice as fast. And we see that versus the standard of care. And you can see the curve going up, whereas with the standard of care, the curve is on the same straight line. And here's just a typical trajectory of a single wound over the 8 weeks. And we're starting at week 0, so you've got 10 images there. And week 4 through to week 8, with week 4 being repeated there. And you can see a nice healing trajectory. Venous ulcers are usually in the lower third of the calf or the gaiter area or around malleoli. And I think this is some of Michael Stacy's work, that they're much less common when they're on the foot or when they're on a higher area. Now you're going to hear about the consensus, but we also took a look at 127 chronic wound patients that had gecko devices with special authorization, and 127 chronic wound patients in multi-center clinics. We looked at improved wound healing outcomes for venous ulcers, diabetic foot ulcers that may be neuropathic, ischemic, or mixed. Ischemic ulcers are mixed arterial venous, and post-surgical are trauma. And there was a common theme of reduced pain, reduced edema, and enhanced patient quality of life. And I think this does tell us that we do have something that can make a difference. Okay, Michael.
Thanks, Gary. Thanks for that sort of overview of some of the data on, why we should be looking at incorporating the muscle pump activator in the way that we manage patients with venous leg ulcers. And so it was some of that prompted us to develop the consensus statement on the management of venous leg ulcers. And our objective in doing this was to incorporate some of that new data, the ones that Gary's just been over, but also new data related to how to use advanced wound dressings, because we don't have a lot of guidance of that in other larger documents, which are guidelines on managing venous leg ulcers. They will often reference it, but don't really direct us. So what do we do when that wound's not healing? And this was trying to get a practical guide for healthcare providers, a short document, something you can have with you in the clinic and refer to when you've got a problem. The key elements of this document are just listed at this point. And as I just mentioned, the new areas that we're looking at, including in the consensus statement, is, how do we further improve the calf muscle pump function? Because that's the key problem in patients who develop venous leg ulcers. Traditionally, we've treated them with compression bandages, but we now know we've got another option to add to that or to use when people struggle with compression bandages. And that the reference there is to the study that Gary just went over, that Keith Harding and his group did. And as I mentioned, we're putting in here some guidance on what to do when they're not healing, and then a structured approach to what to do with some of the advanced wound dressings that are available to us. So I've already sort of touched on this. So the primary thing is to improve the calf muscle pump function in patients with venous leg ulcers. And we know that standard is good level of compression, but not all patients can manage that. And this consensus statement will give you guidance on what to do with those patients. And within it also, we're including, things that are the traditional things that you're very used to, the wound bed preparation concept, the time algorithm of dealing with the tissue, getting rid of devitalized tissue, managing infection if it's present, managing moisture appropriately, and then what to do if that edge is not advancing, what things you can do to help that. And part of that is looking at, an algorithm of how to use advanced wound dressings, because lots of dressings address those other problems that are in the time algorithm. But when a wound isn't healing, there is a sort of a potentially a structured approach as to how you can use these advanced dressings. And the key to that is assessing the wound. So you assess it. If it's not healing, then move on to dealing with bacteria and biofilm. Give it a period. If it's not healing, move on to reducing protease activity. Still not healing, do something to improve the matrix, the bed of that wound, with negative pressure or matrix substitutes. Still not healing, add growth promoting factors. We don't have a heap of options, but we do have some options out there available to us. And then finally, if it's still not healing, then adding additional cells may be the final step. And that may be things like skin grafts, cultured cells, or even there's work on stem cells, but that's out of the reach of most of us as clinicians. So the process that we went through with this, the people who led this, myself, and Gary and Robin, and Keith Harding as well was involved. And then we set about bringing together a panel from across Canada, so looking at people from multiple different backgrounds, physicians, nurses, NSWOCs, therapists, and multiple different regions of Canada. So we had a panel of 19 in total. The process started with drafting a document, which we then circulated to the panel to get initial feedback. We corrected it, resent it, then had a Zoom call where we discussed particular areas that needed that sort of person-to-person discussion. Modified it again, broke it into 23 segments, sent it out then for rounds of agreement, of which we had 2 rounds. Our objective was to get at least 80% consensus or agreement on each of those sections. We're able to get 100% consensus on 20 of the 23, and on the other 3, we got more than 85% consensus. So we feel it was a pretty robust process to get to good consensus in this document. And just to emphasize again at the outset, this was done independent of any input from any wound care companies. So it was really based on the panelists' knowledge of the data, the literature, the use of the products and the devices. These are the panel members. You'll see their a number of physicians, large number of nurses, and NSWOX therapists in there from across different regions. As I said before, a number of them here at this conference, and just like to thank them again for their input into the development of this document. And we have Amanda up here on the stage as well, who is integral to the process as well. So I'll just go through some of the key elements of this consensus statement. So the first part is really, making the diagnosis of a venous leg ulcer. And, one of the key things, when you're dealing with patients with these problems is to actually understand your patient. So that's why this initial part really speaks to that. So yes, we're wanting to understand the cause of their ulcer, but we're really wanting to understand who they are. What's their level of health literacy? What are their environmental factors that impact, their ability to actually seek care, get care, or that may have impacted getting the wound? And what are their actual own individual goals of care? So it's important to have that approach to your patients. And then, we go through a pretty standard process of assessing the history, doing an examination, looking for evidence of venous disease, evidence of arterial disease, and then any underlying conditions that may contribute to the development of the wound or may have an impact on their ability to heal wound, and that includes medications. And then there are a number of investigations we go through, and I'll touch on a number of those as we go through this. Clinical features I won't touch on at this point. I think many of you are very familiar with them, but the document does contain what are the typical clinical features of venous leg ulcers. So if we go to investigations, and in this day and age, the standard investigation that we would mostly do to determine if someone has venous disease is a non-invasive lower limb venous duplex ultrasound. And they're more and more available, but they're not always available to everybody. In past days, we would have used various forms of plethysmography, even sometimes venography. But this would be the standard of care that we'd look at. We also understand that not all, practitioners have ready access to this. So within the document, it does indicate that if you've got something that otherwise is a venous leg ulcer from all other intents and purposes, their arterial status is sufficient, then that shouldn't stop you from going on to implementing treatment just while you're waiting for a confirmation of venous disease with an ultrasound. And the other key element that I think you're all aware of when we're talking about adding compression is you want to know the arterial status. And the standard there is to do an ankle brachial pressure index if you have access to it. And I think we heard in the last session, if there's incompressibility of the arteries, if it's elevated, we'll often go to a toe brachial pressure index, which in most cases will give us an indication as to whether that's normal or not. And then the other option is Gary's already sort of given us that little sound bite of what the audible waveforms are on a handheld Doppler. If you have monophasic waveform, it indicates you've got significant arterial disease. Whereas if you have multiphasic, so either tri or biphasic, it indicates you've got, an adequate arterial circulation to use compression. So certainly something that is an option for people who don't have access to getting an ABPI. The other things there are just around, looking for other problems that patient may have that may impact their ability to heal a wound. I won't go into those in any detail at this stage. The final point there is just also assessing their ankle movement and their gait, because exercise is an important part of managing patients with venous leg ulcers. And knowing if that's something they're able to do is important for you, as it may also have an impact on why they developed it at the beginning. So the key treatment, as I've mentioned before, in patients with venous leg ulcers is to try and improve the calf muscle pump. And the way we do that, the traditional way, is to use compression bandaging. And as long as the patient's got normal ABPIs, then we usually go to an optimal multi-layer compression system, which is usually 30 to 40 millimeters of mercury at the ankle. In most cases, it is a multi-layer bandage system, but there are other options open to us. And you may have elastic or inelastic bandages, you may have stockings, you may have some of the adjustable, wrap systems with the hook and loop fasteners. There are other things like intermittent pneumatic compression, et cetera. So, we look to see what's available, what the patient will tolerate, what they're able to apply, what they can access. But in most cases, it'll be a multi-layer bandaging system. And we also encourage calf muscle exercise and ideally some form of at least supervised or at least some exercise directed by a physiotherapist or a rehab physician. The next question is, and the reality with most patients with venous leg ulcers, not everyone can tolerate optimal compression. So what do you do if they can't? And here, it depends a little bit on what your ABPI is. So if they've got a low ABPI below 5, then you would really try and steer away from putting compression on that leg. If it's above that, and certainly if it's above 0.65, then you'd for sure look at trying to go to a lower level multi-layer compression system. And if it's between 0.5 and 0.65, then you do that with caution. You may just use the stockinette system. But that doesn't fully improve the calf muscle pump function. And we now have the option in these cases of adding the muscle pump activator, which actually adds to that to make sure we can optimize the function of that calf muscle pump. So this is one point at which we'd bring that into our treatment. And if they're not able to tolerate any compression, again, we usually look at just the stockinette, but still the muscle pump activator, because you're doing something that otherwise you can't do because you can't use that optimal compression. And then we still recommend exercise, and we do recommend, for certainly patients with significant edema, elevating their legs regularly through the day. What about the ulcer itself? So again, as I mentioned, this consensus statement incorporates the principles of time just into basically what you do with the wound. And that begins with cleaning the wound and the ulcer. And here, we have available products like hypochlorous acid, which are very rapidly effective antimicrobials and anti-biofilm products. So just using that as a cleansing agent. Many people leave on a gauze swab soaked in that for 5 minutes. Some do it for 10 minutes, just to try and minimize the bacterial load. We devitalize tissue, so the tissue element of time. We look at managing any infection that's in the wound or surrounding tissues, so the I part of time. We manage the moisture. If it's too moist, we have something to absorb, but if it's too dry, we have something to retain some moisture, so the moisture part of it. We treat the surrounding skin, and we also, treat any pain that the patient may have. And there are, as some will recognize, there are patients for whom we really don't think we have an option of getting that healed, and we come up with what is essentially a management plan that maintains that wound and minimizes the risk of infection. And the final point on this slide is one of the key points. What we absolutely must do with these patients is measure their wounds. I was talking to someone earlier today, and I go to my clinic in the vascular lab at Hamilton, and I often see written in the notes of patients with a wound, for 6 months, the wound's looking better, the wound's looking better, and there's not a measurement in sight. So that's just basically not the way to practice when you're managing wounds. You have to measure them. It doesn't matter how you measure them, even if it's a very simple ruler method, or if you've got a more complex one you can use by taking a photograph and getting an automatic measurement. But document the size, because that's how you know whether it's improving or not improving. We recommend doing that weekly. If you see them less often, then do it at each visit. So what do you do if the wounds are not healing? And this is oftentimes what our guidelines don't really help us with. So what are the key things that you should do? Well, the very first thing you should do is make sure you've got your diagnosis right. So if you've implemented a plan, you've got them into good compression and it's not healing. So you should just step back a little bit and say, have I missed something in the diagnosis? Is there something that's causing this ulcer to not heal? Because if it's a venous leg ulcer, you'll expect some response with good compression and good management. just listed there, and the consensus statement speaks to some of those things. And then the next question is, is the treatment protocol actually being adhered to? Because you may provide it. Is it actually being done, regularly in the community? Or is the patient taking it off because they're having difficulty with it? And then also reassessing, is there infection? Because infection will actually make these things stall or go backwards. So it's why you pause and you reassess. So you reassess and make sure you've got the optimal compression system. You make sure they've got an exercise program. And at this point, if you've got all of that in place, if you haven't used an MPA, this is the point to use it, a muscle pump activator. So if it's not responding to what you've been able to do as your best treatment, what Keith Harding's trial tells us is that you'll help that to heal some more if you add the muscle pump activator. And then also, you should consider, sometimes it's not frequent these patients benefit from it, but sometimes some sort of intervention in their venous system, if it's suitable. Many of them aren't, but those who've got an isolated superficial incompetence may benefit from some sort of intervention, either a surgical intervention or one of the less invasive techniques that are available today. And then if you've got all of that in place, you've got good compression, you've got muscle pump activator in place, and it's still not healing. So what are your choices? So again, this is where we're trying to give guidance in this document for people. And, as we know, there are advanced dressings out there. There's thousands of dressings, but there's a small number of categories that actually do something to the healing process. And at this point, the first step is to make sure or address the microbial load. So you may not have active infection, but the microbial load may be impeding it. So at this point, you look at adding a dressing that's antimicrobial and antibiofilm. You do that, you monitor it for a period, you reassess. If it's still not healing, then go up the chain. You look at something that's anti-protease because you may have an excess protease activity that's inhibiting healing. Again, continue, reassess, still not healing, go to improve the wound bed. Options are things like negative pressure therapy or adding a matrix substitute, sometimes combinations of these. Still not healing, then add growth factors. And there are some dressings available that do have growth factors in them. There are some that will be coming onto the market that will help us with that. As you all know, there's been some that have been and gone on the market. Regranix is probably a good example, no longer available to us, but these will come back. And then finally, if it's still not healing, that's when you're thinking, okay, maybe it's now time to add cells, whether it's a standard skin graft or cultured cells or some other form of skin substitute. And then of course, there are other sort of adjunctive therapies that we would also consider. We've listed some of them there. At this point, we didn't feel there's sufficient, evidence for us to put us into this consensus statement, but there may be in the future to incorporate those. And then when you've had a good clinician like Amanda or Robin or Gary looking after your wound and it's healed, then the next challenge is to try and prevent the recurrence. And here, the key element here that the consensus statement speaks to is that lifelong use of compression therapy. So an education to patients on the importance of compression therapy. And also, for them to understand how to prevent injury to the leg that might result in an accident and might result in another ulcer. With compression therapy, we mostly look at compression stockings below the knee, but not every patient will tolerate that. So, we shouldn't stop at that point. What we try and do is to work out, so if they won't tolerate what we believe is an optimal below knee compression stocking, then let's find out what they will tolerate. So it might be a lower level stocking, it might be a hook and fastener, one of the wrap systems, whatever they'll tolerate, you try and get on their leg, because that, even though it's not optimal compression, it will add to their preventative strategies to try and stop these things from coming back. So again, you look at that, and if the final thing on there is if you haven't considered, looking at any sort of venous ablation, maybe reassess, if you haven't done it while they had their wound, then maybe reassess and see if that might help, because that can help to stop recurrences. So that's got to the end of my piece about the consensus statement. I just wanted to finish just to say that this consensus statement has been reviewed and endorsed by nurses specialising in wound ostomy and continence Canada. So we have their endorsement for this consensus statement. If you want to access it, it's freely available to anyone who would like to access it. So on here you see there's a website there, and there's a QR code that gets you to the website. So if you go there, you can download it. You're welcome to use it, share it. This is an independent website, so it's not connected to any company. There's no other material on the website. There is just the consensus statement. So feel free to go there, access it, use it, and share it. So what we're going to do now is to go through a few case studies, and I'm going to ask Amanda to lead us through those, and then ultimately we'll take questions.
Thank you very much. Okay, so when we were looking at the consensus statement, we're going back, I just wanted to go back before we went to these case studies. When we actually look at going back through the actual slides and going through the actual delivery of what you're going to, are you going to add in your silver dressings, your antimicrobial, you're going to address your moisture balance, are you going to add an MMP to it, are you going to add negative pressure? You don't necessarily have to, and I know this is kind of like a ladder form, but you don't necessarily have to go wait 2 weeks before you do the other. And I'm sure as if you go around to some of the vendors, they'll tell you that some of the new literature out, let's say adding MMPs under negative pressure is having really good outcomes, that you can actually do multiple of those steps all at once. So I just kind of wanted to address that part. And that means, like, if you have access to that muscle pump activator, you don't necessarily have to wait till the very end to do those things. Okay, so let's see how well everybody listens while they were eating and digesting their food before the coma sets in. So we'll go case study number 1. You have the 55-year-old male with the ulcer in the gator region of his left leg for more than 6 months. This is his first ulcer. He has a history of a DVT 7 years ago. The wound is 28 centimeters squared in size. You have completed your investigation, and there is evidence of venous disease and no arterial disease. You have commenced him in a multi-layer compression bandage system with a non-adherent dressing, and he has regular exercise program. And after 4 weeks, the wound has reduced to 25 millimeters squared. So what are your initial steps at this 4-week visit?
From what I calculate, that's about 10% smaller than the initial after 4 weeks. And if it's going to heal by week 12, you would really want it to be 30% smaller. So you really have a delay in ulcer healing. And I think the very first thing, you have ruled out arterial disease. I think you need to reassess the wound. Do you have the right diagnosis, or is there an alternate diagnosis that requires other investigations? I think you need to look, is there infection there? Might there be other coexisting diseases that the person has, or are there some medications the person's on that may be inhibiting healing? And then I have a favorite question when I'm assessing pain is, I like the numeric rating scale, but 0 is no pain, 10 slamming your thumb on the car door, and 5's a bee sting. Where is it now? And if it's anything more than a 3 or a 4, then you know that there's something wrong and something else to do. And when's the last time they've had blood tests to look at that component? But what I'm going to do is I'm going to shunt it to Robin and see what Robin thinks. Wasn't that?
That's called passing the buck. But I want to just punctuate this with, everyone says a venous leg ulcer. It's just a venous leg ulcer. These are very difficult to heal. And every one of you have dealt with this. Now, if we've ruled out absolutely everything, and I think that's the point of this case is, and Dr. Sibbald's alluded to the fact that there's no other medical comorbidities that are delaying the healing here. So one of the things I wonder about with multi-compression is, first of all, is it the correct multi-compression for him? But if everything else is correct, I think you're at a point where you need to consider something else. And what is that something else? Well, you could consider something like pentoxifylline, which has got evidence for venous disease. And you could consider something else and ensure that the calf muscle pumps are being done correctly. Person's wearing the correct shoes to activate the calf muscle pump. And then you could move on to something to try to improve the calf muscle pump, because obviously Mother Nature installed that method as being the better one. So doing something like neuromuscular stimulation could be an option for this patient. But I would also say, this patient doesn't look, this is his first ulcer. We don't know how much lipodermatosclerosis he has and all of that business that might impact what else you would be doing and how effective your compression would be.
I think it's interesting that he had a DVT previously, and you'd want to know if he was on anticoagulation. I like the idea of the pentoxifylline, though. It's a xanthine, and it's got side effects like caffeine, but it is fibrinolytic. It does increase red blood cell contractility, and it's also got some anti-inflammatory properties. And if you like, the pentoxifylline is working from the inside out and the compression from the outside in. And you're getting a complementary thing. And my interventional cardiologist son tells me that it's not a contraindication if somebody's on anticoagulation to take pentoxifylline. And we were, sometimes we were reluctant to do that. Yeah, then this is another comment.
No, I was saying if it's Coumadin, you can still use it, but you have to watch the INR much more carefully. That's all.
Okay, great. Okay, I think that was good. So one of the things that also too, when we look at whether the actual person is compliant with compression, how many people actually tell their patients to take off their compression if they're in multi-layer wrap, have a shower, and then come into their clinic? How many people tell them to do that? Okay, so one of the things too is, are we actually managing the edema? So when you're looking at this, just because they're wearing that multi-layer compression wrap, is it actually managing that edema correctly for them? And are they actually keeping it on? And how quickly does that edema return for them? So if they're actually taking that, in the morning, they're taking the wrap off, they're having a shower, and they come see you in the clinic, at 8 o'clock at night, and now they're getting that yo-yo effect of that. So making sure that they truly are wearing it that full length of time and how well you're actually controlling it. Okay, so let's move on.
One of the things that patients will often say, look at the marks on my leg. It's, my arteries aren't getting to the leg. And, one of the best things to tell patients is that the only good wrinkles in life are the wrinkles under compression bandaging, because it shows it's working.
Nice. Okay, so actually we covered those other ones too. How many people are wearing compression here today? Not very many. Wow, I've got mine on. Okay. So case number 2, a 66-year-old female patient who has an ulcer on the gaiter region of her right leg. Her walking is also limited by calf muscle pain in both legs at approximately 100 meters. What investigations do you want to do on this patient? What is your treatment plan while you're waiting your investigation? Who wants to take this first? First, you take some.
So you would want to do some arterial assessment. So physical exam or appropriate history, and then referral to do some vascular studies, depending on your findings, if the patient is truly having claudication at 100 meters. So I would want to ensure that the arterial supply is good.
What about investigations right at the bedside that the nurses can do?
Well, I do the pulses, and you can use what you have at your disposal. Would that be ABIs or a Doppler, something that would give you some confidence that the blood flow is good. And if not confidence in that, then doing more extensive studies elsewhere.
Okay, we're trading first and second here. I guess the other thing that can happen, though, is you can have an angiosomal defect or a local defect, and you may have normal ABPIs. The other thing that is interesting that can cause pain and is often overlooked is to have a livedoid vasculopathy, not a vasculitis, but a vasculopathy. And this is where you get atrophy blanche, and in venous disease, you often see it around the malleoli. But we published with Dr. Alavi that if it's at the base of the toes that you see the atrophy blanche and more diffusely distributed over the foot and even the gaiter area, you have to think about a more systemic process. And this can sometimes, you get little necrotic areas because atrophy blanche is really necrosis or a lack of circulation to the skin in that area where you lose appendages and you lose some blood flow. And it can be really painful.
Yeah, and I think the other thing, in this situation, obviously you're thinking some arterial disease and you're going to seek to get some confirmation of what it is. But if we're assuming you can't get that done at the bedside yourself, then you've still got this patient with this ulcer. So what are you going to do with them? And then, so because you don't know their ankle brachial pressure index, you're going to be reluctant to apply any significant compression until you know that. So your simple options to, obviously you'll put something on the ulcer, but just putting a simple stocking add-on does a little bit. It's not going to, put you at risk of problems with that. But then this is a point at which using the muscle pump activator device will actually do something for the calf muscle pump function. So you've got something, it's in the gaiter region, almost certainly a venous leg ulcer. They've almost certainly got combination of venous and arterial disease. So until you know your ABPI and you know what compression you can apply, this is a great opportunity to improve calf muscle pump function with a muscle pump activator and just use a simple stockinette. So you guys, any comments on that?
Yeah, no, I like that idea. Sometimes the pain, and I get consults, or when I was going into the hospital more frequently, bilateral cellulitis, not better with 2 weeks of IV antibiotics. And there can be acute inflammation of the lipodermatosclerosis. And that kind of inflammation can be exquisitely painful so that patients don't tolerate compression. So there are other reasons for pain in venous disease. And if somebody's got a deep clot, you put compression on and you take away some of the superficial collaterals, you can also end up with increased pain.
Yes, I think this case is one where your hands are kind of tied and you don't have much compression to use. And if you really want to get this better, I think you need to improve the calf muscle pump. So having an option of using a stimulator would be a good thing to do, along with trying to get them to do calf muscle exercises.
Yeah. I definitely think, when you're looking at using the calf muscle pump, there's only positives to that. If they can, if they're tolerating that, increasing the blood flow while you're waiting for those types of exercises. And I think a lot of people think that because there's arterial insufficiency there, that they never want to put on any compression. I think it's a really good point that just even putting on very, very mild to start off with, to get rid of that superficial edema, kind of decreases that compression on the internal arterial system.
Just to add to that, I think we didn't really show the data on it in the beginning, but we also know the muscle pump activator increases arterial flow. So if you're at all worried about, this patient, and you add the muscle pump activator, not only are you going to help their calf muscle pump function, you're also going to improve the arterial microcirculation for them as well. So that itself may actually help the wound to heal.
So her ABI came back at 0.75 on the right leg and 0.8 on the left leg. What is your treatment plan going in your next step? So I'm not sure if we didn't kind of cover that part.
Yeah.
Yeah. Okay. So case number 3, you have been asked to see a 74-year-old male patient with limited mobility in a long-term care facility. He has had an ulcer on his right lower leg for 9 months. That is a clinical appearance of a VLU. He has been refusing compression wraps because he finds them too uncomfortable. So what do you want to do in the assessment of this patient?
I think first of all, you would feel for a pulse and do a good physical exam of looking at whether there's any dependent rubor and pale on elevation. Look for signs of venous disease and look for things like atrophy blanche and lipodermatosclerosis so that you're collecting data. Make sure the ankle moves so that you do have calf muscle pump action, and you know, ask about pain and ask whether or not this patient sits up in a chair or not. And then I think once you determine, and I would be putting in long-term care and in these kinds of patients, this is where the audible Doppler is much easier than having somebody laying flat for 20 minutes and it's influenced by calcification. It's painful when you have to blow up the cuff around the calf when all you have to do is listen to a signal that isn't influenced by calcification, and you're able, and if it's multiphasic, I would start with something really low, and whether each layer of tubing grip correctly fitted, it's about 8 millimeters of mercury, or your actual edema wear works by longitudinal compression, and there's a fuzzy wale, about 80% of it's open. And at the intersection of the crisscross, there is a thing called a fuzzy wale, which gives you differential capillary pressure. So it's working in a way that's different than normal circular compression. It's longitudinal, and it's much like the principles used in physiotherapy taping. So I think you have some alternatives to add a little bit before you add a little bit more. And Robin?
I think this is working. Well, I think the issue with this gentleman is he's got limited mobility, so I think his legs are recumbent most of the time. And I think if Dr. Sybil's suggestion of using compression is a good one, but the reality is when someone's sitting recumbent for hours on end in a day, you're really fighting a process that's difficult. And so this might be an option to use something else like a stimulator to try to improve the function here, or also engaging physiotherapy to try to help with the ankle mobility. I think all of these things together, there's never one thing that's a magic bullet, but I think looking at maybe light compression, neuromuscular stimulation, if you will tolerate it, and together with some sort of physiotherapy to act to help with this would be ideal.
Great. Yeah, I think too, when looking at the reason why he doesn't like, for someone who kind of works in long-term care, the reason why he's actually not putting on the compression. So it can be numerous reasons. Sometimes they just don't like the actual, the wrap. It's if they have any type of dementia or anything like that, they don't like actually the wrap on there. So sometimes looking in what the actual rationale is why they don't want the compression to begin with, but definitely the calf muscle pump to get the wound healed, and then preventative measures, often just putting them into a compression sock. So that's more normal for them, getting in them a compression sock, and even something even a little bit bigger so that it's not so hard to get on, or into those Velcro wraps, because lots of times it's also PSW support who don't actually like to struggle with those socks, and then the patient just goes, yeah, I don't want it, and then they just leave it.
Yeah, so I think the other thing with this one, and I totally agree with everything everyone said, I think, you know, you want to look at some form of, you know, what even light stocking you can get on. But then adding the muscle pump activator, particularly in an immobile patient, I mean, what it does, it works for the 12 hours you've got it on. So if they're sitting there with their legs recumbent, it's actually getting that muscle pump, calf muscle pump functioning. But the other thing that you know, we find with this is that if you do that, you get them in a stockingette, sometimes once you get the swelling down a little bit, it becomes a bit more comfortable. You can start to introduce a little bit of compression. And I think that's one of the other sort of hidden things that sometimes you find with the muscle pump activating device. Your goal should always, assuming you've not got any major arterial problem, to try and get them into, some form of light compression. And I see in our last point here, the ABPI it's above 0.5, but it's only 0.55. So you're only ever going to go to light compression. But if you're using muscle pump activator, it might get you there and enable you to do something more positive for this patient's problem.
Getting the wound healed and then the preventative measures. Yeah.
We're at time.
Okay, so do we have any questions from the audience?
No.
Hi, I'm Jacqueline. The screen when you were talking about failure to heal wounds and all the things that you can look at in the way of interventions, do you ever employ a dietitian to look at, you're dealing with a lot of seniors and you're just wondering about their nutritional needs, are they being met?
That's actually working. So in a long-term care facility, one of the things that they do, and at least in all the ones that I'm in, as soon as they have a wound, dietitian is always referred to in long-term care. So absolutely, that's something that is in all of my treatment plans, dietitian right off the get-go for that.
But it is a challenge in the community to engage a dietitian, but it is the right thing to do.
There is also a nice, the Canadian nutrition screening tool, and just ask 2 simple questions. Have you lost any weight in the last 6 months you weren't trying to lose? And are you eating any differently in the last week?
Okay, we are at time. There are a few questions, it looks like, on the chat, but I think at this stage we've got to pause because we've got another session coming on. But firstly, thanks very much to all the audience members for your input and your thoughts on this. And thank you also to Perfuse Medtec for putting on this session and supporting this. So thank you very much and enjoy the rest of the conference.